Hello, am I audible?
Yes, you are audible.
Okay. Sorry for the trouble. So let's begin to our next toxicology series. Today we will be learning most commonest poisoning that we encounter in our emergency department. It's paracetamol toxicity. Let's begin with a clinical scenario. Just imagine you are the emergency physician on duty and it's around at 2 a.m. It's after a busy schedule, you are taking some rest. The time a 22-year-old female, she walks into a ED and she tells that she took 30 tablets of 650 mg paracetamol following a suicidal attempt. And on examination, the patient is completely fine. She's asymptomatic, vital stable. Now, her bystanders, they're asking you, doctor, the patient is completely fine. Can you discharge the patient? What will you do? Will you discharge the patient? So for answering this question, let's start with the what constitutes the toxicity of the paracetamol. How does the paracetamol is causing the acute liver injury? We learned that first. Okay. So let's calculate the dosage. This girl, she has taken 30 tablets of 650 mg paracetamol. 30 into 650 equals 19.5 gram. So just remember the toxic thresholds. For adult, more than 7.5 gram or 150 mg per more than 150 mg per kg. And for children, more than 150 mg per kg acute ingestion of rapid release paracetamol is the toxic threshold. So in our case, it's 19.5 gram, definitely toxic. So even though the patient is completely asymptomatic, the patient needs urgent evaluation and management. How does this paracetamol is causing the acute liver injury? Let's learn the metabolism of the paracetamol. Just think like a story. When the paracetamol get absorbed, most of the paracetamol, that is 90% of the paracetamol, is metabolized by the glucuronidation and sulfation. Sorry, am I audible? Okay. So most of the paracetamol, 90% is metabolized by glucuronidation and sulfation. And it will get metabolized into inactive component that will eliminated through urine. Okay. The other remaining 10% that will be metabolized by oxidized by the cytochrome P450 system. And it will generate an active component called NAPQ, N-acetyl P-benzoquinimine imine. It is highly dangerous. However, fortunately, in normal circumstances, this will be rapidly detoxified by our glutathione, our barrier. So when the liver injury occur when the paracetamol is consumed in a large quantity, the normal pathway, the first pathway will be saturated. So most of the paracetamol will be metabolized by the second pathway, by the cytochrome P450. And the NAPQ component will be generated more and more. Once the glutathione stores get completely depleted, this NAPQ will bind to the hepatocytes that will cause the irreversible necrosis. That is the one causing the acute liver injury. And here our NAC will act. We all know that the paracetamol poisoning antidote is the NAC, N-acetylcysteine. So here the action of NAC will come. It will act as a glutathione precursor. Okay. So you can see the metabolism here. I hope all you understood the metabolism. Then let's see the clinical manifestation of the paracetamol toxicity. This will be, the patient will be maybe presenting at different stages. So we can classify this into 4 stages mainly. The first stage will be from 0 hour to 24 hour. Here the patient will be having some anorexia, nausea, vomiting, some non-specific symptoms maybe they will be telling. Come to our patient. This patient had no symptoms at all, right? So some patients will be like that. They will be asymptomatic. Second stage, that will be from 24 hours to 72 hours. Here the patient will be feel better actually. Even though the liver changes begins here, the patient feel better. That's why, just remember this thing, the severity of the symptoms doesn't correlate with the severity of the toxicity, especially during the early phase of the paracetamol poisoning. The third stage, here the hepatic injury that become evident, the laboratory abnormalities that will become clinically apparent. Some patient will be again having symptoms like nausea, vomiting. They will develop jaundice, hepatic encephalopathy, renal failure, myocardial damage. All this can happen, and even death can occur due to the acute liver injury in the third stage. In the fourth stage, those who have survived the third stage, they will gradually improve. Okay. And our liver is having an excellent power. It can regenerate. So only few will develop chronic liver changes secondary to the paracetamol poisoning. Then, how will you investigate this patient? Again, just think about our patient. This girl came 3 hours after the ingestion of paracetamol. So how will you investigate this patient? Just see. Serum paracetamol level is the one best investigation we need to send. However, we'll send this investigation only 4 hours after the post-ingestion of the paracetamol poisoning. Why? Because if you are checking the serum paracetamol level before 4 hours, you may be getting a false value because the absorption will be incomplete before 4 hours of the post ingestion. So that false information can mislead you in your management. That's why 4 hour post ingestion paracetamol level is recommended. Okay. And along with that, you can also send the other investigations like LFT, PT-INR, serum creatinine, other electrolytes, glucose and all. And especially if you are suspecting any other co-injection, you can check the VBG, pH value, CBCs, ECGs. Okay. And you should also reassess the patient before discharging or before at the end of the NAC therapy. You should reassess the patient to decide whether the NAC therapy should continue or you can discharge the patient. That also based on the reassessment. Okay. And whether the urine toxicology, is it having any value here? Actually, no, because the urine toxicology can only detect the paracetamol level. It's just a qualitative test. It cannot tell you whether this can cause hepatotoxicity. It cannot help you in the in guiding the NAC therapy. Okay, so always just remember the serum paracetamol level is the useful test other than the urine toxicology test. Come to our McMathew nomogram. It is a graph. It is helping us in giving the NAC therapy. Here, there is an x-axis. In the x-axis, the time will be mentioned, and in the y-axis, the serum paracetamol level will be mentioned. Earlier, the graph was like starting with the 200 microgram per ml deciliter. However, now the level has lowered by a 25% to increase the sensitivity. Okay, so now the line begins with a 150 microgram per ml. And how you will use this graph? So after getting the serum paracetamol level, you will plot that value on this graph. And if that point is coming below the line, the treatment line, that means that is not that toxic. So no need to give the NAC therapy. And if that point is coming above the treatment line, that means it is toxic. It is above the threshold level. That patient requires the NAC therapy immediately. Okay. And which all patient we cannot use this nomogram? Those who are presenting after 24 hours of the post injection, or those who are taking this repeatedly about the supratherapeutic injection, or chronic overdose patients, or those who don't know the time of injection. In those patients, we cannot use the nomogram. The nomogram is useful only for from 4-hour post injection to 24-hour post injection. And in acute injection of rapid release poisoning, only in that only it is applicable. Okay. Uh, I'm showing you this graph to understand the metabolism easily and the use of NAC. Okay. In this graph, the black line that is showing the hepatic glutathione stores. So initially that will be abundant, but as time progresses, that will get depleted. In toxicity, I'm telling, okay. So by the 12 hours, the glutathione stores will get completely depleted. That time you can see that red line, that is the unbound toxic NAPQ. That will get starts rising. So that rising means the unbound NAPQ, it will go and bind to the hepatic cells, and that will cause the hepatocellular necrosis. That hepatocellular necrosis is marked like a yellow dotted line. Okay. So that's why we are telling if we are giving the NAC as early as possible, especially within 8 hours of the paracetamol poisoning, it will be most useful because this NAC is a glutathione precursor. It will help to replenish the glutathione stores. It won't reverse the hepatocellular necrosis. So it is most useful if you are giving within 8 hours of paracetamol poisoning. But that doesn't mean the NAC is not having any use after that. Okay, right. Then come to the treatment algorithm. Again, think about our case. The lady, she came 3 hours after the injection of paracetamol poisoning. How will you approach this patient? As we discussed earlier, so she came within 3 hours. We can try the gastric lavage and we can give the activated charcoal. It is actually indicated if the patient is coming within 1 hour activated charcoal. And we have to wait till 4 hours to send the serum paracetamol level. Okay. Then we will send the serum paracetamol level 4 hours after the injection. Then we will plot that on the nomogram. If the dot is coming above the treatment line, we have to start the NAC. If it is below, we don't need to. But in our case, we already know that it is a highly toxic dose. So in those cases, and we know the report won't be available within 8 hours of injection, then we can start the NAC therapy actually like if the patient, sorry, again I will tell you, if the patient is taken paracetamol more than 150 mg per kg and the serum paracetamol level is not available within 8 hours of the injection, then we can start the NAC therapy immediately. Okay. Then, what if the patient is presenting within 8 hours to 15 hours post injection? In that case, immediately we can send the serum paracetamol level and along with other investigations. And we can start NAC here also if the patient is already taken the paracetamol more than 150 mg per kg acute injection. Okay. The same only applicable in the next case also between 15 to 24 hours. And what if the patient is presenting after 24 hours of the post injection? In that case also, we can start the NAC immediately if the dose is more than 150 mg per kg, and immediately we can send the serum paracetamol and other associated investigations. Okay. Come to the NAC regimens. We already know there are two regimens existing. One is the intravenous NAC therapy, other is the oral NAC therapy. The intravenous NAC therapy that we are giving over the 21-hour and the total dose we are giving is 300 mg per kg. During the first hour, we will be giving 150 mg per kg in 5% drugstores, 200 ml of the 5% drugstores over 1 hour, followed by 50 mg per kg, 500 ml of the 5% dextrose over 4 hours, and 100 mg per kg in 1 liter 5% dextrose over 16 hours. If we're giving in children, we should be concerned about this thing. Hyponatremia can develop in NAC therapy. So that should be dilated to 40 mg per ml. Okay. Come to the oral therapy. In the oral therapy, it is over 72 hours we are giving. And with the loading dose of 140 mg per kg, we will be starting. This we will be giving along with some juice or carbonated drinks because it will be having some unpleasant taste. And followed by the loading dose, we will be giving 70 mg per kg every 4 hours. 17 doses we will be giving. Okay. And I would like to give you a recent advance. Nowadays in US and UK, they are following a 2-bag regimen actually for the IV therapy. Here we are following 3-bag regimen. Over 1 hour and 4 hour and 16 hour we are giving. But nowadays they are following 2-bag regimen. But they are giving the total dose same as 300 mg per kg only. But that will be over 4 hour and over 16 hours. That is just to avoid the anaphylactic reactions that is related to this NAC therapy. Okay. So let's see. What if an anaphylactic reaction is developing after the NAC therapy? This is reported only in 20% of the patients. That too, unfortunately, those who are having low doses of serum paracetamol level. Some may develop some respiratory issues. Some will be having some itching urticaria. It is anaphylactoid reaction. And in this situation, how you will react? It is, you can follow, just pause, treat, then you can restart. Just pause the NAC therapy, notice this allergic anaphylactoid reactions. Then you can treat it. Like if the patient is having any respiratory symptom, you can nebulize the patient with salbutamol. Or if the patient is having any allergies or urticaria, you can treat it with antihistamines and steroids. And once the patient becomes better, you can restart the NAC therapy. Okay. Then, how will you decide whether the patient we can discharge or we should continue the NAC therapy? At the end of the therapy, you should assess the patient's laboratory parameters like INR you should check and LFT you should check. Serum paracetamol level also we can check. If the INR is 1.3 or less and the ALT it is normal or less than 2 times of the upper limit and the patient is completely asymptomatic, then you can discharge the patient actually. Those who are having a raised level of ALT that is more than 2 times of the upper limit of normal value or the INR is prolonged more than 1.3 or the patient is still having the symptoms of acute liver injury, then you should continue the NAC therapy. How you will continue the therapy with what dose? That will be same as the third infusion. Dose and rate will be same. Okay. And just think, what about our patient, that lady? She was pregnant. How will you treat that girl? The treatment will be same. Same NAC therapy with the same dose. Because the NAC is safe in pregnancy. NAC can cross the placenta, but it will protect the baby and the mother. One more scenario I will give you. The same girl, she came to your ED, so you know that this is a toxic dose she has taken. And when you are calling to your pharmacy, the NAC is not available. What will you do? Initially, you can do the same thing. You can stabilize the patient. You can check the airway breathing circulation. If the patient is presented within 1 to 2 hours, you can do the gastric lavage. You can give the activated charcoal. And you can send the other laboratory investigations. And meanwhile, you can try to arrange the NAC, or you can contact the other centers to refer this patient for NAC therapy and further management. You have tried all these measures. Even then, there is no way. You cannot refer the patient. There is NAC is not available. Then what you will do? One last attempt. I will tell you one thing. You can give this drug called methionine. It's a amino acid actually. It will also have some action. It will also give some protection for the liver. The dose will be like 2.5 gram every 4 hour, 4 doses. Total 10 gram for an adult. Okay. But remember, NAC will be the antidote for the paracetamol poisoning. Okay. Then you have again think about the same lady. You have given all the treatment. You have given the NAC therapy. You have reassessed the patient. When you are reassessing the patient, you are seeing that the patient pH is around 7.2 even after proper hemodynamic support resuscitation. The pH is 7.2. Or else you think that this patient's prothrombin value is more than 100, creatinine is around 4 or above that, and the patient is having a grade 4 hepatic encephalopathy. How will you manage this patient? This is the ideal candidate for the liver transplantation. So for that, we are having a criteria that's called King's College criteria. So here we can check either here we have two types. Either you can just see the pH level. The pH is, if it is less than 7.3, despite of the fluids and hemodynamic support, you can elect the patient for the liver transplantation. Or else you can check the patient prothrombin value or INR, creatinine, and assess the patient. And the prothrombin is more than 100 or the creatinine is more than 3.3 and patient is having hepatic encephalopathy stage more than or equal to 3. Then this patient is requiring the liver transplantation. How, and some values that will give you an idea before the end of the NAC therapy itself, whether this patient is having poor prognosis. Okay. That is arterial lactate level. If the 4-hour arterial lactate level is more than 3.5, that means the patient is having a poor prognosis. So by the time itself, we can uh, think like that this patient may be requiring the liver transplantation. So just think that in your mind, okay? I will give you a mnemonic to remember this thing. Okay, it's a rule of 3 for a PCM overdose. Here, APCM means A means acidosis, P means the prothrombin time or INR, C means creatinine, M means the Mendel status. So the rule of 3 is that the pH it is 7.3 if it is less than 7.3. Okay, or prothrombin time, it is more than 100. 100 is the first 3-digit number. Okay, or INR, if you are thinking, it is 6.5. You can think like 6.6 also. It is 3 into 2. And the creatinine value is 3.3. You can remember, or it's 300 micromoles. Mendel's change means the hepatic encephalopathy grade 3 or more than 3. Okay, so I think it will be easy to remember for you guys. So recent updates we already discussed. So come to our patient. So now you know what is the toxic threshold and how is this metabolism is happening, how should you approach this patient, how you will manage. Just rewind everything. Think about our patient. It's a 22-year-old female. She has taken 30 tablets of 650 mg paracetamol. So its total dosage is 19.5 gram, definitely toxic. This patient is coming to you 3 hours after the post-injection of the paracetamol. overdose. So how you will approach this patient? As we discussed, you can do the gastric lavage initially. You can give the activated charcoal, and then you can wait till the 4 hour after the post ingestion. 4 hour after the post ingestion, you can send the serum paracetamol level and you can plot that on the nomogram. If it is coming below, you can just observe the patient, or if it is above the treatment line, you can start the NAC immediately. But in our patient, we already know it's a highly toxic dose. So no need to wait. Actually, you can start the NAC immediately and reassess the patient at the end of the NAC therapy. If the patient is not improving, just think about the King's College criteria. If the patient is an candidate for the liver transplantation, then just contact the referral center or just do the arrangements for the liver transplantation. Thank you. I hope all you have already understood the paracetamol toxicity. It will help you for the exams. It's a simplified version. If anyone is having any doubt, you can ask.